This recorded lecture will be going over Chapter 21, the Neurologic System. The nervous system consists of the central nervous system, or the CNS, and the peripheral nervous system, or the PNS. The spinal cord is a conduction pathway for impulses going to and from the brain, and also serves as a reflex center for nerve impulse transmission. Sensory impulses travel to the brain on ascending conduction pathway tracks. Motor impulses will travel on descending tracks. This picture can be seen on page 485, showing the main divisions of the central nervous system. A stimulus is a physical, chemical, or electrical event that changes the cell membrane and initiates conduction of the stimulus as an electrical impulse along the nerve pathway. The stimulus will travel from one neuron to another across a synapse. This is the space between two neurons. A neurotransmitter secreted by the neuron is necessary for transmission of an impulse across a synapse. Acetylcholine, dopamine, and norepinephrine are the major neurotransmitters. When the neurotransmitter is absent or decreased at the synaptic junction, the stimulus cannot travel along the nerve pathways normally. After impulse interpretation, a message may be sent out from the brain through the spinal cord or cranial nerves for appropriate action to be taken. In other words, a stimulus produces a response. When myelin is destroyed, like in multiple sclerosis, impulse transmission is slowed or stopped. The functions of the SNS result in moving skeletal muscles. SNS movement can be conscious and voluntary or reflex type activity that does not involve a conscious decision. The ANS helps maintain homeostasis by regulating organ systems. The PNS is subdivided into an afferent division and an efferent division. The afferent division carries impulses to the CNS. The efferent division carries impulses away from the CNS. The autonomic nervous system of the PNS is active in maintaining internal body balance. This is homeostasis, and it is also automatic or involuntary in its actions. Sympathetic and parasympathetic nerves have opposite effects on many organs. The cranial nerves and their functions can be seen on table 21.2 on page 487. The meninges are protective membranes that cover the brain and are continuous with the membranes covering the spinal cord. The meninges consist of the pia mater, which covers the brain, the arachnoid, which encases the entire CNS, and the dura mater, which is a tough membrane protecting the brain and spinal cord. CSF serves to cushion and protect the brain and spinal cord. Normal CSF pressure measured during lumbar puncture should be 100 to 180 millimeters of water pressure, or 7 to 13 millimeters of mercury when side lying, or 200 to 300 millimeters of water, or 15 to 22 millimeters of mercury when sitting. When there is an excessive amount of fluid in the subarachnoid space, the CSF pressure rises above normal. The brain requires a constant flow of oxygen to function. The brain's neurons cannot survive anoxia for more than 4 to 6 minutes. The brain can auto-regulate the flow of blood for a constant supply. Blood provided to the brain arrives in waves consistent with the pulsatile flow from each heartbeat. The vessels into the brain constrict or dilate as needed so that the brain receives a continuous supply of oxygenated blood. The pressure within the skull, or intracranial pressure, should normally be 5 to 15 millimeters of mercury. The volume of brain tissue, CSF, and cerebral blood flow will determine ICP. Disorders causing swelling of brain tissue, increased CSF, or increased blood flow will all increase ICP. An ICP greater than 20 will require treatment. Once destroyed, cells in the brain cannot be replaced, but other brain cells can pick up their function. In the PNS, The Schwann cells can regenerate the myelin sheaths that wrap around the axons in the PNS. Neurotransmitters that affect the transmission of nerve impulses can be seen on page 488 within table 21.3. There is a loss of neurons with aging. Loss of neurons and slower nerve conduction will cause a decrease in efficiency of the ANS with advanced age. The aging process affects recent short-term memory, but long-term distant memory is often not affected. The ability to learn is not affected by aging, but the learning process is slower. It takes longer to process new information. Pupils decrease in size with advanced age, and more light will be needed for reading. Degeneration of the myelin sheath with age will result in slowed reflexes. Many factors can affect neurologic function, including genetic and acquired developmental disorders, infections and inflammation, benign and malignant tumors, vascular or neuromuscular degeneration, and metabolic and endocrine disorders can all cause damage to or interfere with normal function of the nervous system. On page 492, within box 21.1, we can see classification of common neurologic disorders. A complete neurologic examination is a very long procedure and is usually not indicated for the hospitalized patient. Components of that complete assessment will be routinely done on each patient, and a more detailed evaluation can be completed for patients with neurologic disorders. Because neurologic disorders can be present in conjunction with or in addition to disorders of other body systems, you should include questions about neurologic status in the initial and ongoing assessments for all patients. Patients who are suspected of experiencing a neurologic problem will receive a more in-depth assessment. Basic neurological assessment would include assessment of the level of consciousness and mental acuity, muscle strength, and the presence of any deficits, including speech, swallowing, or unilateral weakness. Changes in blood pressure, particularly a rise in systolic pressure and a widening pulse pressure, could indicate an increase in ICP. Changes in breathing pattern will often indicate a problem with neurologic control of respiration. Current vital signs should be compared with those from the previous several days to determine any changes or trends. The Glasgow Coma Scale is a tool that can be universally used in one form or another for the purpose of assessing mental function and level of consciousness. The patient's LOC can be scored in 3 different categories. The first category is eye-opening, the second is best motor response, and the third is best verbal response. The score in each area will be added together, with the optimal score being 15. That indicates a fully alert patient. A score of 3 would indicate a totally comatose patient. A score of 8 or less indicates coma level. The 4, or full outline of unresponsiveness score, has been developed by Elko Wijix, a neurologist at the Mayo Clinic, and it is becoming the preferred scale to use to assess comatose or intubated patients who cannot speak. For an alert patient, you should note changes in mental function by asking questions to determine orientation to person, place, and time. Thinking can be evaluated by asking the patient to add 3 numbers together, to count by 6s, to solve a simple puzzle, such as if the man goes to the store and purchases 4 oranges at 40 cents each, 2 apples at 60 cents each, and 2 bananas for 46 cents, how much did he spend? It would be okay to allow a pen and paper to be used. Judgment can be grossly tested by assessing whether the patient has been making rational choices in their day-to-day life. This can be done by asking them what they would do in a particular situation. While watching the patient perform morning activities of daily living, basic assessment of cranial nerves and motor function can be performed. Assess the following. Does the face move symmetrically when the patient smiles? Is their speech clear when they answer questions? Do they move left and right extremities without any noticeable problems? Is there anything abnormal about their gait as they move across the room or down the hall? Do they have difficulty eating or swallowing? Observe the pupils of the eye for size and equality. Pupils should be equal size and should constrict and dilate readily when the environmental light changes. Evaluate the extraocular muscle movements. Ask the patient to follow your finger while you move it through the cardinal portions of gaze. Note whether both eyes move together or conjugate, or if one deviates. Note any back and forth oscillation or nystagmus of the eye as the endpoints of each direction. Neuromuscular assessment is concerned with the function of motor pathways. You can test each of the upper and lower extremities by asking the patient to follow verbal commands, such as raise your left leg, bend your right knee, touch your elbow with your right hand, and touch your face with your left hand. Have them push against the palms of your hands first with one foot and then with the other to test the strength of the leg muscles. To test muscle strength, you can have the patient extend their arms in front of them and then press down on one arm at a time while asking them to try to raise the arm. Pronator drift can be determined by having the patient hold their arms out in front of their body with their palms up and eyes closed. If weakness is present, the weak limb will drift downward and the hand will turn inward. This is known as pronating. The portion of the neurologic examination assessing coordination and balance will evaluate the functions controlled by the higher centers of the brain. This is the cerebrum and the cerebellum. The patient will be asked to stand with their feet together and to close their eyes. This is called a Romberg test. If their sense of balance is normal, a steady posture will be maintained and there will not be swaying from side to side. Next, ask the patient to walk across the room. As they do, assess their gait. Then, stand in front of the patient, hold up a finger, and ask them to touch your finger and then their own nose. Move your finger to different locations as you do this in front of the patient. This tests both the ability to follow directions and coordination. A reflex is an action or movement that is built into the nervous system and does not need the intervention of a conscious thought to take place. It is an automatic response. The knee jerk is a great example of a simple type of reflex. In addition to testing the patellar reflex, a neurologic examination could include testing of the biceps reflex, triceps reflex, brachioradialis reflex, and the Achilles tendon reflex. Reflexes will be graded as follows. A 0 out of 5 means absent. 1 out of 5 means a weak response. 2 out of 5 is considered normal. 3 out of 5 is considered an exaggerated response. And 4 out of 5 is considered hyperreflexia with clonus. Clonus is a continued rhythmic contraction of the muscle when there is continuous application of stimulus. The Babinski reflex can be elicited by firmly stroking a blunt object, like a key, along the sole of the foot. In a normal response to this stimulus, the toes should bend downward. In a positive Babinski response, the great toe will bend backward and upward, and then the small toes will fan out. A positive Babinski reflex in an adult who is not under the influence of chemical substances would indicate an abnormality in the motor control pathways leading from the cerebral cortex. The 12 cranial nerves control both sensory and motor activities within the head and neck. Cranial nerves 2 and 3 control pupil movement. When ICP rises beyond a certain point, pressure on these nerves causes changes in the pupils. It is best to measure pupil size rather than to estimate it. The size of the pupils in relation to each other is more important than the actual millimeter size, which can change with ambient light. Examine the pupils in a room with low light, where the pupils would typically be dilated. Then direct a bright light into each eye from the side while the other eye is covered. Observe whether the pupil into which the light is shining is constricting, and whether it does so briskly or sluggishly. Finally, shine the light into each eye while watching to see if the pupil constricts in the other eye. This is known as a consensual reflex. When pupils have been previously reactive, changes in pupil size or reactivity can signal an emergency, and the healthcare provider should be notified immediately. To test for accommodation, this is the ability for eyes to be able to focus on near and far objects. You can ask the patient to look at an object across the room away from the light source, and then look at your fingers held about 6 inches from the eyes. The lens should change shape and the pupil should constrict. Normal pupil response is typically charted as PERLA. This means pupils equal, round, and reactive to light with accommodation. Pupils that remain dilated and fixed in the presence of a bright light would indicate brain damage if there are no drugs in the system affecting the pupils. One pupil that remains fixed and dilated indicates increased ICP. Sometimes changes in pupils can be caused by medications. If the patient does not respond to voice commands at all and deafness is not an issue, you should test their degree of unconsciousness. First, use a louder voice to try to arouse them. Then, if they don't respond, gently shake them as you would to awaken a child. If that is still not successful, a painful stimuli can be applied. A central pain response can be elicited by firmly pinching the trapezius muscle at the angle of the shoulder and neck, slightly twisting and increasing pressure for 10 to 20 seconds. Historically, a sternal rub has been used to evaluate a pain response. However, this is no longer recommended since damage to tissue and bruising often occurs with this method. The levels of response to pain are purposeful withdrawal from the stimulus or an attempt to push it away, non-purposeful response in which the patient may frown or move the arm or leg in a random way, posturing or failure to respond at all. Posturing that could be exhibited would include flexor posturing. This was previously called decorticate. This is demonstrated by the extension and stiffening of the legs, adduction of the arms with the forearms bent upward, and the wrists and fingers flexed on the chest. This type of posture would indicate damage to the cortex. You could also see extensor posturing, previously known as decerebrate. This is where the arms are stiffly extended and held close to the body. The wrists are flexed outward and the legs are stiff with toes pointed downward. This response would indicate damage to the midbrain or brainstem, and this is a very serious injury. For a comatose patient, tests are performed to determine brainstem function. After ruling out spinal cord injury, the oculocephalic or doll's eye and oculovestibular reflexes are assessed. You can see more information about this on page 501 within table 21.8. After ensuring that the tympanic membrane is intact, the oculovestibular reflex can be assessed by caloric testing. Monitoring the neurologic status of a patient with a known neurologic disorder includes a neurocheck on a set schedule. It is performed to determine whether increased ICP is present or ICP is rising. 4 areas will be monitored: vital signs, LOC, pupil reaction, and motor function. Neurochecks can be ordered as frequently as every 15 minutes or at intervals from 2 to 8 hours. The diagnostic tests most commonly used to evaluate the neurological system can be seen in table 21.6 on page 496 through 499. Overall goals for patients with neurologic disorders will depend on whether there's a physiologic possibility that full function could be regained. A goal for all patients with neurologic disorders would be to prevent injury, whether from complications of immobility, accidents related to lack of sensation, aspiration due to difficulty swallowing, or any other problems that the neurologic deficit could cause. Caring for patients with neurologic deficits can be very time-consuming, and it will require considerable patience and understanding. You can see this pupil gauge scale on page 495. And you can also see this picture on page 495, checking the extraocular eye movements. You can see demonstrations of the flexor and extensor posturing on page 502 if you want to put a visual with the description. Extended time should be included in the daily work plan when caring for neurological patients. Respite care can be available, and it is very helpful in allowing caregivers to take a break from the physical and psychological stress of caregiving. Positive coping skills should be reinforced and ongoing support offered. Progress in the patient experiencing a neurological deficit will often be slow. Long-term goals of a realistic nature are appropriate. Keep in mind that certain types of neurological deficits, like those caused by spinal cord severance, may not improve. Goals are based on preventing complications rather than improving function. When caring for a patient status post-head injury and their respirations change, change drastically by decreasing, you should notify the doctor ASAP. You can see some more about this within Table 21.9, Common Problem Statements, Goals, Expected Outcomes, and Nursing Interventions for Patients with Neurologic Disorders. Weakness of the diaphragm or respiratory muscles, or interruption of normal brain function can occur with a variety of neurologic disorders. Monitor the adequacy of respiratory effort and promote a patient airway and chest expansion. Elevating the head of the bed 30 degrees can allow the diaphragm to drop more easily and promote chest expansion. Respiratory assessment is performed every shift and includes auscultating the lungs for signs of atelectasis or retained secretions and judging the quality of the respiratory effort. If respiratory efforts are considerably impaired, the patient may need intubation and mechanical ventilation. Activities such as proper positioning and range of motion exercises are started immediately to preserve proper alignment of joints and limbs and prevent contractures and muscle atrophy. Patients with hemiplegia, this is paralysis and loss of sensation in an extremity, will be taught to become aware of arm and leg placement whenever turning or transferring to a chair to prevent injury to the affected extremity. A patient with left hemiplegia from a CVA could neglect their paralyzed side. They must therefore be taught to attend to the affected side of their body by scanning it frequently. Support the affected arms with pillows or an armrest to keep it from dangling when the patient is seated. Patients with hemiplegia are taught step by step the safest ways to transfer from the bed to the wheelchair and back, as well as how to use assistance from others. They are also taught how to care for and protect their skin in areas of decreased sensation. Patients with hemiparesis, or one-sided weakness, will be taught to strengthen their muscles and use assistive devices. Patients with tetraplegia, which is 4 limbs paralyzed, will be helped learn how to cope with their drastic, life-changing alteration, as well as how their energies can be directed towards a different but attainable goal. An older term for tetraplegia is quadriplegia. All patients with a recent impairment of mobility will need help with the grieving process. Support in establishing healthy and effective coping patterns and assistance with depression. Attention to pain relief and muscle spasm is necessary for these patients to achieve the highest level of rehabilitation possible. Assess joints for tenderness and pain before performing ROM exercises, and be gentle and considerate when turning and repositioning them. Take measures to promote skin integrity. Place the patient on a special bed, mattress, or protective mattress cover or pad. Inspect pressure points frequently and keep the skin dry and clean. Denervated skin is more susceptible to skin breakdown than tissues with an intact nerve supply, so extra effort should be made to maintain skin integrity. Neuromuscular impairment can interfere with the patient's ability to perform hygiene activities and other ADLs. Inability to carry out the most basic self-care activities can erode a person's sense of independence and self-esteem. The ability to feed, clothe, and take care of toileting is an important part of independence. If the patient is unconscious, the mouth should be kept clean to avoid infection of the parotid gland. The lips should be cleansed and lubricated at frequent intervals because mouth breathing will make them excessively dry. It is easiest for two caregivers to work together to rinse and suction the mouth. Oral suction should be available and turned on anytime mouth care is given to a patient with a weakened gag reflex, who can't swallow normally, or who has weakness of the facial muscles. When the patient cannot shut their eyes, you or a caregiver must provide care to prevent keratitis or corneal ulceration. Artificial tears or a lubricant can be instilled as prescribed to prevent dryness. Goals for rehabilitation must be realistic and mutually agreed upon by the patient, the family, and the healthcare team. Assistive devices can help patients with neurologic deficits to feed and dress themselves. Provide assistance when the patient cannot do a task completely, and most of all, provide encouragement and praise for efforts made. When pursuing self-help rehabilitation, remember that the patient will tire easily. Tasks should therefore be spaced apart so that energy is available to achieve them. Every patient who has suffered a neurologic insult from head injury, stroke, or intracranial surgery must have their swallowing reflex assessed. A bedside nursing swallow screening should be performed to determine if it's safe to give oral medications prior to the speech therapist doing a formal examination. Check periodically that the patient automatically swallows saliva before offering water. Patients with difficulty eating are at risk for nutritional disorders and aspiration pneumonia. Depending on the mechanism of the dysphagia, various head positions can be used to facilitate passage of food without aspiration. It is recommended not to lay flat for 30 minutes after eating. When the patient cannot swallow without choking or aspirating, tube feeds will be necessary. Many patients with CNS disorders experience temporary or permanent urinary or fecal incontinence. Constipation or urinary retention can lead to organ dysfunction if not promptly corrected. Bladder training is a program designed to help a patient with some degree of loss of normal bladder function and a resulting disturbance of voiding and bladder control. The purpose of a bladder reconditioning program is to prevent urinary complications like infection and calculi, and to allow the patient freedom from fear of embarrassment as well as loss of their self-esteem. In developing a bladder reconditioning program, the patient's mental and emotional ability to cooperate and take an active part in carrying out the program is evaluated. Spinal cord injuries and lesions produce what is known as cord bladder or neurogenic bladder. Patients with disorders of this type are not aware of the need to void and must be trained in techniques to initiate voiding and emptying the bladder. A bladder training program will typically begin with a 2-hour schedule for toileting. Coffee, tea, alcoholic beverages, and soda with caffeine should be avoided after dinner because they have a diuretic effect. A trial of 6 weeks is necessary before determining whether the training is successful. Patients who have nerve damage and paralysis are trained in specific techniques to empty the bladder. Self-catheterization is taught to patients with paraplegia so that they don't have to be dependent on an indwelling catheter or on other people for their urinary elimination. Intermittent incontinence should be expected and should not be looked on as a failure. Achieving total continence will take considerable time and effort, but it is possible for many patients. The bowel training program can begin with an assessment of the specific patterns of elimination. It will also help to know the patient's former bowel pattern before their illness or injury. Bowel training for either constipation or incontinence should incorporate an exercise program that is within the patient's ability, a high-fiber diet, and an adequate liquid intake throughout the day. For patients who are prone to constipation and incontinence, increasing liquid intake and administering a stool softener can be effective. Many patients with neurologic disorders experience pain. This pain is often chronic in nature. Teaching the patient about pain and its relief, the adverse effects of stress, anxiety, and unpleasant stimuli, and the benefits of distraction from the pain will become part of the plan. Depression often occurs with chronic pain and lack of sleep. Confusion may be acute and short-term, or it can be a permanent state. A person in a state of disorientation will remain in the state of disorientation, and until the symptoms subside, they may not be able to behave rationally. Therefore, they must be supervised and protected to prevent injuring themselves. Acute confusion is known as delirium. This is typically an acute, short-term state, usually caused by fever or metabolic imbalance. Patients who experience confusion after a head injury will often become combative as their ICP rises. A patient who is confused needs, above all else, a stable and calm environment. Stimuli entering the brain are frightening and threatening, and they simply cannot make sense of what is going on around them. Attention to safety of the patient is a priority. Confused patients will need a dependable, consistent schedule. Patients with memory loss who can still read will benefit from written instructions, as well as posting a day schedule with activities. Aphasia is a defect in the ability to express oneself in speech or writing, or an inability to comprehend spoken or written language. Aphasia can be receptive, expressive, or global. A person with receptive aphasia has difficulty interpreting communications in either spoken or written form. With expressive aphasia, the person has difficulty expressing themselves in speech or writing. Global aphasia occurs when the person has a combination of receptive and expressive aphasia. A patient who suddenly has a problem speaking or understanding words or signs will be likely to feel isolated and extremely frustrated unless an effort is made to establish some means of communication with them as quickly as possible. Goals for the care of aphasic patients are focused on stimulating communication without undue frustration. Perhaps the most important rule is to avoid talking to an aphasic person as if they are mentally incompetent. The patient should be spoken to, not spoken about, as if they could not hear or understand what others are saying in their presence. Speak slowly and distinctly in a normal voice while always facing the patient. Use body language and sign language to communicate if it seems to help the patient. Give aphasic patients plenty of time to respond to questions, and do not ask more than one question at a time. If you need to repeat a question or statement, use exactly the same words. Keep the environment orderly, relaxed, and relatively free from distractions that would make it difficult to concentrate on communicating. Some general guidelines would include the following. Give praise for attempts at communication and for correctly expressed words or sentences. Excuse me. Do not correct the patient's pronunciation, as they are liable to become too frustrated and may just give up speaking. Be very patient. Total speech rehabilitation can take many months, and it may never reach their pre-aphasia level. Writing treatments can also be used as therapy. Sexual dysfunction from a lesion in neural pathways should be dealt with by allowing expression of the patient's concerns, beliefs, and feelings. The patient will need time and assistance to adapt to an altered body image. Be accepting of the patient's expressions of anxiety, anger, denial, regression, and depression. Collaboration with the social worker concerning referral to support groups and interactions with others who have similar disabilities who are coping well can prove to be most beneficial. A chronic neurologic disorder that disrupts normal function for the patient will also disrupt normal family roles within the family. Family members will need to be included when educating the patient about their disorder, the possibility of remissions and exacerbations, and the self-care measures necessary.